joining us, and Dr. Nan is here. Great.
Okay. Hi, Dr. Nan.
Hello, hello.
Hi, Dr. Nan. Good morning.
Good
Good
morning.
morning.
How is everyone?
Good.
Yeah,
How about you?
I'm fantastic. I apologize for being late. My last meeting ran over a few minutes.
okay. That's
Good.
that's fine. That's fine. That's great.
What did you say about the participants? I'm seeing the other screens popping up now.
Okay.
Is that is
So
that the way you
yeah,
wanted it?
started. So we are good. Okay, so we can start. Um, okay, so some of the day to you wherever you're joining us from, and welcome to the Lab to Doctors webinar titled Eliminating Pre-Analytical Errors Prior to Sample Collection. And this webinar is proudly brought to you by Lab to Doctors. I hope you're having a great day wherever you are. And if this is your first time hearing about Lab to Doctors has been doing amazing things, and we'll hear more from Dr. Chesie when it is time. So I'm excited about today's conversation because it's not just another routine lab talk. In laboratory testing, there's a crucial phase that is often overlooked. And this phase is where the large part of lab errors occur. And I'm really delighted that today we get to have this conversation, we get to talk about it. And before a sample is even analyzed, damage could have already been done. So I'm glad we get to have this conversation. So take notes, of course, and buckle up. If today is your first time being on here or listening to our two amazing speakers, we are happy to have you. And I am your host, Olayemi Takuro, and of course, I'm not doing this alone. I have with me my co-hosts, my beautiful co-hosts, and she is.
Hi everyone, my name is Harper Hires, and I'm so happy to be here. Um, so we're going to move forward with introducing Dr. Chesie Voma. She is a passionate researcher, educator, and clinical scientist, and a mentor in the health and laboratory sector. Her quest for knowledge has led her to become a top voice in laboratory medicine by birthing Lab to Doctors, where she provides her dedication to redefining lab result accuracies, correcting patient diagnosis, and with this, saving lives. She understands that one small error can change a lot. So please welcome Dr. Chesie Voma.
That's amazing. Thank you, Harper, and it's great to meet you, Dr. Chesie. Also, I am delighted today to welcome a top professional pediatrician. She's a coach, a physician, and a mentor. And over the course of her impactful career, she has made significant contributions to the healthcare industry. She's not just in clinical space, but she's building healthier and more resilient teams. She's a founder of Beat Down Burnout, and she understands the critical need for balancing clinical precision with human vulnerability. And she has helped numerous healthcare organizations create lasting change, unlock their team potential, and foster an environment where people feel seen, heard, respected, and empowered. Let's make welcome Dr. Nanette Nuessle. It's great to have you here today.
Thank you so much.
How are you doing today? And Dr. Chesie, Dr. Nan, how's the weather?
Doing great. I'm looking forward to this discussion that I think has been past due.
Oh, that's great. That's great. Dr. Nan, what about you?
I'm doing fantastic. It is really rainy here right now. I'm in the Midwest, and we've had
Oh,
a series of storms coming through. This is the time of year when we're usually worried about drought, and it's like not going to happen this year. We can take that off our worry list.
I hope not. All right, then. So let's head straight into this conversation. So, Dr. Chesie, could you elaborate on the nature of pre-analytical errors and, of course, tell us how their prevalence is within the routine laboratory operations?
So yeah, pre-analytical errors basically are the errors that happen in the pre-analytical phase of lab testing. And
Okay.
this pre-analytical phase, like it says pre-analytical, it is the phase before testing takes place. And this phase comprises of from when the clinician selects the test to be ordered, the test is ordered, the sample is collected, the sample is transported under the right conditions, the sample is prepared for testing. All of this make up pre-analytical phase of testing. So today we're talking about the errors that happen in the pre-analytical phase of testing. But more importantly, for this webinar, we are trying to raise awareness of the role that patients have in ensuring the quality of their results. Any of us could be a patient on any day. Even clinicians would one day be patients. And it's important for us to know that we are important stakeholders when it comes to ensuring the quality of results released from the lab. Pre-analytical testing contributes to 60 to 70% of the laboratory mistakes. And if pre-analytical testing alone, the phases I just described to you, contributes to 60 to 70% of laboratory testing mistakes, this means there's definitely a problem. Why?
Right.
Because it can lead to misdiagnosis, delayed treatment, the cost of retesting, and what about managing a disease, especially for chronic diseases like diabetes and hypertension? So this makes pre-analytical testing very important, that I believe that it's important for the patients to also know that they have a role to play in the quality of results that are released from the lab.
Okay. That's a great response. Thank you so much, Dr. Chesie. Harper, do you want to add to that?
I have nothing to add. Dr. Nan, do you
Oh,
have
yeah,
any experience?
I certainly do. And the pre-testing errors that I mostly see have to do with phlebotomy. Was the test drawn at the right time? Was the right amount drawn? Was it put in the correct tube? Because all of those things, if not done the way they're supposed to be done, create a delay in care. And it's gotten to be commonplace, at least in what I'm seeing in pediatric hospitalist arenas, is that it is commonplace for labs to be drawn late because the hospitals are rural hospitals in particular are so short-staffed when it comes to phlebotomists that your 8 a.m. labs may not get drawn, or your 6 a.m. labs may not get drawn till 8 a.m. And the ones that are supposed to be run stat don't get run at all until after all those labs are drawn. So by that time, the results may be completely unhelpful because there's no longer any clinical context for them. I see patients getting stuck repeatedly because not enough blood was drawn, or it was drawn and placed in the wrong tube. But I recently saw one that just blew my mind, and that is we did a blood culture on a sick newborn, along with several other tests. We did a blood culture. And when we tried to track down the results of the blood culture, no one could find where the specimen went. And it literally took 2 hours of my time, plus time from 4 other staff members, and eventually involvement of the chief nursing officer, before we learned that the tests went to a completely different lab than what we were led to believe, and that there was an error in processing within the lab, which we were able to create. It's wonderful when we can find a systems error, because that's something we can fix. It's a little harder when it's just a matter of staffing.
That's
right.
really powerful. No. Okay, Dr. Chesie, do you have something to add to that?
Yeah, everything she said are actually the things that happen with some of the errors. And this series of errors that she made mention of in the lab, we call them exogenous errors or in vitro errors, because these are errors that happen after the sample has been collected and before the sample is tested. A lot of things can go in between if it's not stored under the right conditions, transported immediately. There could be things like due to chemical instability, you could actually have drugs in the sample degrade. You could actually have microbial growth because the sample has not been stored under the right conditions. You could also have like cell lysis, whereby you have the chemical substances that are within your red cells or your white cells being released into the sample, thereby causing us to submit falsely elevated results because the cells inside the sample, the tube were lysed. And then we also have things like protein and enzyme degradation, or
Okay.
because of these are some of the things that happen when this sample is missing in action. I just call it missing in action. Nobody knows where it is. By the time you locate the sample and test it, it's not the same thing like when the sample was just collected to be tested.
Absolutely.
And the other thing
So,
she made mention of, we have a chronic shortage of laboratory staff currently. So
uh,
she made mention of that.
yeah.
It is a chronic shortage, which means that because of all of these kind of things, you're unable to have the samples, the results very accurate if you do not have the right number of staff put in place to have
Yeah.
that sample tested. So these are all things that we go through. And these are some of the reasons why lab to doctors came to existence. Because you have these people out there, sometimes the lab cannot even answer that question. So lab to doctors basically came up to have a team of laboratory medicine professionals that would actually quickly attend to you even faster than the lab that did the testing. So you know
Mm.
your next steps. Instead of letting a patient sitting there sick and feeling miserable, and then a doctor who really wants to take care of their patients cannot get response from a lab because the lab is short-staffed.
Mm.
Yeah.
Dr. Nan, what would you say is the cause of this laboratory personnel shortage? What would you think from your perspective, right? As a pediatrician, what would you say is the reason why there are so much shortage of personnel in the lab?
I don't know that I can answer that as a pediatrician, but I can certainly answer that as a coach. It has
Okay.
to do with the culture of healthcare in America right now.
Okay.
Um, we have corporations who are trying to squeeze everything they can out of every single staff member, from housekeeping to physicians and everyone in between. So phlebotomists are being expected to draw more draws in an hour than they were before, and they're actually being expected to work longer shifts than they did 5, 10 years ago. Um, I know this for a fact, not only because of my contacts at work, but because I had a family member who was a phlebotomist and left her job to go get a job at Walmart because it paid better and it had better hours.
Wow. Mhm.
Yeah, that's the crisis we're in. Honestly, it's not just phlebotomists and lab personnel. It's throughout healthcare. I've had medical office assistants leave and go get a job at McDonald's for the same reason.
Hmm. That's a little, I mean,
It's
Harper, do you?
it's eye-opening.
It is eye-opening indeed.
Yeah,
And
it's shocking, honestly.
okay, so Dr. Nan, I would also like to, before we launch straight into this conversation properly, would you like give us a background information? What inspired you to become a pediatrician? And especially beat down burnout is amazing. I mean, you're doing great helping people who work in the healthcare sector. And I'm sure we have a lot of them listening to you today, perhaps for the first time. What would you say was your inspiration? Yeah.
When I was 5 years old, my daddy took me on a trip. He pulled me out of kindergarten, and my sister and I got to go visit my grandparents all the way on the other side of the state. My brother didn't get to come because he was in second grade and they said he'd missed too much school. While I was there, there was an accident and I sustained second and third degree burns to my face, hands, and chest.
Oh.
And I was in the hospital for 3 weeks before I could even be transported back to my hometown. I was in the hospital for another week there. Didn't get to finish kindergarten, but was allowed to go on to first grade the next year. And I continued to have surgery 2 to 3 times a year from the age of 5 or 6 until I was 23 years old.
Mm.
And I went into medicine to pay forward the care that I was getting there. And at least that's what I thought at the time. What I later learned is I went there because it was where I felt safe. At school, I was horribly bullied, not just by the students, but by the teachers because of the scars on my face. At
Wow.
home, well, home was an abusive situation. And so the hospital was literally the only place I felt safe and the only
Mm.
place I felt valued for who I was.
Wow.
And then I got into med school thinking, oh, it's going to be safe too. Med school, working in medicine, not a safe environment. And after watching several of my colleagues get bullied and being bullied myself, I went through some coaching courses and started the company.
That's such an inspiring story. I mean, the fact that you're able to found a community at the hospital, it's really great. It's not something that everyone gets to witness. Just like you said, there's a lot of thinking because you have scars. There are a lot, I think there are a lot of people also going through this. So I think it's really great that you created Beat Down Burnout from this and you decided that this was the occupation that you wanted to do. It's amazing, really.
Thank you so much. I appreciate that.
Okay, so Hopper, do you have a question to ask?
Yes, so let's go ahead with our second question. This is for both of you, but so Dr. Chesie, why don't you start us out? So given that pre-analytical errors occur prior to sample analysis, including phases such as test selection, patient preparation, specimen collection, handling, transportation, and sample processing, which of these areas, in your opinion, offer the most opportunity for patients or their caregivers to meaningfully contribute to error prevention or reduction?
Thanks for the question. I believe that patient preparation offers the most opportunity for patients and their caregivers to contribute to error prevention or reduction in a meaningful way. And like I said, the patients cannot always say that the doctor is not diagnosing me well, or the doctor doesn't understand me, or nobody knows what is wrong with me. If you consistently are not ensuring that you're well prepared prior to your sample collection. Thank you.
And Dr. Nan, do you have anything that you can add to this?
Can you give me that list again, please?
So there's test selection, patient preparation, specimen collection, handling, transportation, and sample processing.
Ooh, all of those are good. But in terms of the one the physician or patient can modify, the physicians, I think their best choice is to modify test selection and the timing of those tests.
Okay.
And that can be done in a way that assists the patient and recognizes their lifestyle. For example, if you're coming in for your annual physical, a lot of us don't realize that after a certain age, that's going to mean certain labs that are supposed to be fasting. So we set up an appointment at 2 or 3 in the afternoon and they want us to fast. If we're told to fast from like 6 p.m. the day before. That's not really reasonable. And as a physician, if we see a patient coming in after 10 or 11 in the morning who was supposed to be fasting and wasn't, we can take a little compassion and say, it's perfectly fine if you fast tonight and come back tomorrow for this test. Our lab opens at 7:30 in the morning and they will accommodate you so that you can still do that and get to work on time. There are options in the way we word things, in the verbiage, and it would be great for physicians to be taught some scripting around these things.
So it sounds like a little bit more bedside manner. A little bit more.
Yes.
Okay.
Keep in mind that doctors aren't taught this. They're only taught to go see the patients, and they're now being pushed to see more patients in the same amount of time with fewer staff members to help them. So if the lab or someone with lab experience were to write out some scripting for them, and they just keep it as an index thing, like a little cue cards on 3x5 cards. Here, this is what you say to this person. This is what you say to this person. And I literally know doctors who have so few interpersonal skills that you have to tell them how to even greet their patients. So taking that intellectual burden off of them and writing that for them would be huge.
Okay.
This is something you could use to grow your website for lab to doctors and your following for lab to doctors. If you created something like this, several things like this, and made them a downloadable PDF for people.
So yeah, I'm glad that you're talking about this because currently lab to doctors has these lab medicine professionals to address these situations. The other phase of lab to doctor, which is something currently being taken care of in the back, we are working on an AI solution to do just what you said.
Yes.
Yes, we're working on doing that because even if we put like 50 lab medicine professionals on the platform to take the calls from patients and clinicians, we will never be able to address everybody's situation. So just what you said is what we are working on. I'm happy that it came from the mouth of a doctor. Thank
Thank
you.
you. And, you know, even if you have a doctor with good interpersonal skills, if the patient they saw before you died or had to be emergently sent to the ER from your office, you may not be in the right frame of mind to think about, you know, switching from that patient to the one in front of you is hard. And any tools you can give us to help with that is greatly appreciated.
Thank you. I can definitely relate with that, what you're saying.
That's great, Dr. Chesie. I was about to ask you what tools is the lab to doctors, playing, a role that you can play in minimizing patient.
You're muted? No. Okay.
Okay. So
I
can you hear
lost
me? Do
your
you hear?
voice. I lost your
Okay.
voice somewhere.
Okay. So I was about to ask you that what tools does lab to doctors have, to induce or to help minimize patient-induced pre-analytical errors in laboratory testing. So I'm glad that you made mention of that just now. So, Dr. Chesie, to what extent can digital platforms like lab to doctors play a role in minimizing, patient-induced errors? Because particularly we're talking about patient preparation before the sample is collected, right? So
Yes.
what tools do lab doctors have in place that can assist, patients to better prepare themselves before the sample is even collected?
Thank you. So currently we have clinicians who have us on their team to help prepare their patients before the sample is collected. And we also have clinicians who reach out to us after these errors have happened and the results are inconsistent with the clinical picture, and they just need help troubleshooting that result, else the patient will be producing the same results over and over. So what we do is when the clinician notifies us that let's say I need my patient to have A1C done, we reach out to the patient or the patient reaches out to us, and then we collect information from the patient. This has to do with the lifestyle. When I say lifestyle, it can be anything like running, jogging, smoking, and then this also has to do with the supplements that the patient takes, prescription medications, and just even herbs that the patient drinks. Because like most of the times people who are older than 40, some of the things that they used to cook start becoming things that they drink in the name of tea. So they would drink
Yes.
black tea, purple tea, and little do you know that all of these things you drink, when they get into your blood, some of them interfere with the lab test. And so when it interferes with the lab test, it causes the wrong results. So we just try to know everything about the patient. What have you done within the last 7 days? What did you drink? What did you smoke? What activity have you been involved in? What has changed? What has changed with your diet? And we ask all these questions with respect to that test, because every test has a different requirement. For example, hemoglobin A1C, there are 8 different manufacturers of hemoglobin A1C. In these 8 different manufacturers, there are 4 different methods, implying that these 4 methods have different chemistries that could be affected. So it all depends on, okay, my doctor needs me to do this test at LabCorp, or we need to do it at Quest Diagnostics. When you say it, we know the method that is used by the lab, and then we can go down the hill to be able to ask the right questions with respect to you as an individual. Then we are able to tell you, you need to stop this, you need to not take this. With permission from a clinician, maybe you need to stop some prescription medicine, if the risk outweighs the benefits. After we prepare you, we now give you the okay to go and have your blood drawn so that the clinician can actually be able to diagnose and treat you. So that's what we do at Lab to Doctors.
Thank you, Dr. Chesie. That's amazing because, as you made mention of the fact that you listen, right? Love to doctors, you have professionals that listen because it happens that oftentimes we see doctors that when their patients come in to tell them what's happening with them, right? They try to diagnose you based on what they are seeing. They're not necessarily listening to what you are telling them that is wrong with you. They just try to think that, okay, this person has ulcer, okay, these are the symptoms, right? Meanwhile, it can be as a result of other things that happened, right? Just like you said, like interference or anything in the blood that could cause that. And that process could also lead to misdiagnosis. That could even lead to something more serious and more severe than the reason why the person went to the hospital in the first place. So in situations like this, what would you say to the doctors? Would you say doctors should listen more, or would you say patients should be more laudable about what you're saying, or what would you advise?
So this is a little tricky. And again, that's why Lab to Doctors was created. There is a gap. There's an intake that doctors do when the patient comes in. They collect all this information. But again, the intake is limited to what the patient tells the doctor, right? And on the part of the patient, sometimes the patient doesn't even know what to tell the doctor. Maybe the patient doesn't know that green tea or black tea would affect my labs. The patient is like, I just drank my tea, so why should I be telling him, right? But when you have a lab professional on your team, they would be able to better bring out this because this is what we are trained to do. Like Dr. Nan said, they are not trained to do this in medical school. So
Yes.
this is the gap. And again, when you come to the lab is not going to ask you these questions. The lab just is going to test that sample. So all of that information goes to nowhere in the lab. And again, that is why we saw the gap between the lab and the doctor. That's how we came in to be able to be that bridge that would facilitate this communication between the two parties.
Dr. Nan, I wanted to also contribute to this conversation from your
Yeah.
view.
So
Maybe you walk with
my experience as a patient is that doctors gather all this information ahead of the appointment time. It's not really the doctors that are gathering that. It's the clinic, the corporation, the electronic health record that is gathering that. And I've had my physician ask me about X, Y, and Z. I'm like, I spent 2 hours filling out that information a week before my test. He's like, I can't see it at all. That does not flow over to my part of the EHR. I have no access to that. Again, this is a systems error that needs to be addressed because if a patient is going to go through the work of answering all those questions, as a physician, I want to see that before I walk in the room. I want to see all of that and see what questions that formulates in my mind so that I'm not taken off guard when I go in there and the patient says something.
Thank you, Dr. Nan. Sure. So, Harper, do you want to ask any questions?
So Dr. Nan, I'm curious for when you're working with children, because you're a pediatrician, what practical steps can caregivers and healthcare professionals take to reduce patient-induced pre-analytical errors from sample collection in children? Are you focusing on like talking to the parents a little bit more, or are you also explaining to the child like what?
We're also explaining to the child at the level that their age should be able to understand, and maybe a little bit more than that. But children are really simple. Most children do not have chronic medical conditions. So when you're ordering a test, whether it's a lab test or an x-ray, it's an in-the-moment situation where so-and-so got hurt or got sick and we need this information right now. So that's simply a matter of ordering the right test. The exception are when we do the physical for entry to high school. And in some kids, if they have a family history of hypercholesterolemia, we will do lipid testing. And so the education for that, again, needs to happen a day or two, or maybe even a week before the visit, so that they know whether or not they need to be fasting. They understand why they need to be fasting, and we work with them to have that done at a time that works for them. I'm fine with patients who need these tests coming in a week before or a week after our visit. If they're going to come in a week after, they need to understand that I may change what advice I give them in the visit to something different after I see those results. And again, that's just a matter of meeting your patients where they're at. That's all it is. Do you
Thank you,
agree,
Dr.
Chesie?
Yes, I definitely agree. You're very correct. Definitely agree. Again, I feel like the burden is on the patients. Yeah, I feel like the patients are not really aware that they have a role to play in letting their clinicians diagnose them.
So I have a bit of a follow-up question. So when you encounter parents who have, done their own research and might not agree with certain testing and would prefer their child either to get something alternative or just to not be tested at all, how do you accommodate that? Or do you try to persuade them to change their minds? Or, how do you navigate that situation?
I don't try to persuade anyone to change their mind about anything until I understand why they want what they want. So if someone comes in and says, well, I don't want this lab test, I want that lab test, I'm like, that's very interesting. I didn't even know you knew about that other lab test. Can you tell me more? And they may be looking at a definitive test for a diagnosis where I think it's important to get a screening test first to see if that second test is even worth it. And sometimes if it's something like that, it's a conversation of, okay, your insurance company will cover that after we do the other tests. And sometimes it's a matter of them educating me as to which test really is the better test for the situation. I'm open to that. Most doctors are. The younger physicians are even much better at this than I am.
Okay.
Okay, thank you, Dr. Nan. Dr. Chesie, do you want to answer that?
Can you say the question again, please? Repeat the question.
So my question was, when you are dealing with maybe a patient or even like parents of the patient who have done like their own background research and might want to go against what you're suggesting as a professional, and they might either just want to completely disregard what you're saying or maybe come in with a different option. How do you navigate that situation? And do you try to persuade them, or do you let them do what they suggested?
Yeah, from a clinician's perspective, I would say that I am in agreement with what Dr. Nan said. But from a laboratorian's perspective, I would want to tell Dr. Nan that even while wanting to accommodate what your patient wants, you may want to reach out to a laboratory support service provider or the laboratory to make sure that this is something that can be accommodated and that it would have no interferences. Because like I said earlier, every lab test has an interference. So maybe the lab would be able to guide you and the patient or the parent to be able to let you know if this is a good decision or not. Just letting the patient tell you, I don't know how far the research was done to be able to validate what we know in the lab. So I would say add the lab component to it.
That's excellent. And I know that when I have not done that, I've made mistakes like sending a sample off on dry ice when it didn't need to be and completely ruined the sample. So yes, your point is quite accurate. Thank you.
You're
Do
welcome.
you think that there should be more, maybe more communication between lab professionals and physicians?
Dr. Chesie, you want to go first or do you want me to go first?
I want you to go first. I want to hear what
Okay.
you say.
So this question was asked of me about pharmacy about 20 years ago. And a lot of physicians, since they study a semester of pharmacy in medical school, feel like they know a lot about it. My dad has a PhD in pharmacy and actually taught pharmacy at a pharmacy school in my hometown. I grew up knowing more than most doctors before I got into medical school. And as I went through medical school, through conversations with him, I realized that there's so much more I don't know. And it wasn't until I was out in practice for several years that pharmacists started rounding with us in the hospital. And it made a huge difference in terms of drug-drug interactions and interactions between their drugs and their diet. And I see a role for lab supervisors to do the same thing.
That's an interesting perspective. I like that.
Okay. Dr. Chesie, do you want to add something now?
I think she has said it all. I strongly believe that there's a role for labs to mitigate the issues with clinicians. But then let me tell you, the shortage that we are currently experiencing in the lab would not permit any lab to step out of the lab and do this. Again, that is why Lab to Doctors was created. We are the lab outside of the lab because we are so short-staffed. We are so we lack resources that would even troubleshoot and investigate these results. We lack the personnel that have the knowledge to actually do this, that sometimes we do not even want to, stretch the few staff we have, we are currently having in the lab. So that makes it difficult for the lab to stretch even further to provide this service. We are willing to. For the most part, you will find the services in university teaching hospitals where we train. But out of a university teaching hospital, let's say like commercial labs like Quest Diagnostics and LabCorp, you are not going to see the services there. So it all depends on, it's good to have it, but again, the resources are so limited, that we cannot even afford to stretch any further.
Yeah.
So in a situation like that, so if I'm a physician at a community hospital and I've got 10 patients I need to round on today, but I'm just hospital, I'm not office that day. There is a role for you guys to step in and I could do a video or audio call with you and say, hey, these are my patients, these are their medications, this is their diet, this is their problem list. And you could enhance the patient and clinician experience. Is that correct?
That is correct. Again, like I said, because of the shortage of resources in the lab, the lab, I don't see any lab capable of allocating their lab director, or, because typically every lab is staffed by not more than 2 lab directors. I don't see any lab willing to dedicate one of the lab directors just to do this. But it is something that would really be nice, that someone from the lab steps out of the lab to ensure that, to answer your questions and ensure there are no interferences or interactions that are affecting the results. It's a need. It's a need. I definitely agree with you, but being in that space, trust me, I am also a lab director, and there's no bandwidth for me to step out and take a Zoom call or a video call to answer those questions. Sometimes when they come, they just pile up on my desk and the secretary takes them, and then at the end of the day I have to start looking at them. The patient is no longer with the doctor, so I'm looking at it at the end of the day, and somebody's suffering with disease somewhere, and when the patient is angry to an extent, the only person they know to blame is the clinician. Meanwhile, the clinician doesn't needs that support from the lab. So that again, that piece is missing.
Mm-hmm. Yeah.
Okay. Alayemi, do you want to move on to the next question?
The volume is not there, Olayemi.
Yeah, okay.
Harper, you can take it.
Yeah, I'll go to the next question. So this is directed for both of you. I guess we'll start with Dr. Nan first. Can you share an instance where a patient-induced pre-analytical error led to a significant diagnostic or treatment challenge? And can you describe how you intervened to resolve the situation?
I really can't, because we don't see that that often in kids.
Mm-hmm. Okay. So maybe we can just pivot to Dr. Chesie, and I'll come back with another question.
Yes, and I'm happy she said that they don't see that very often in kids. Again, lab to doctors was set for people 40 and above, because that's when we are, the blood pressure starts going up, weight gain starts coming in, and then all the herbs that are existing on Amazon, the ones that are in your cabinet, all the spices, you start looking for things to do, and they are the ones that are creating the issues in the lab. So on my part, I'm going to make mention of one of our clients. So this was a 53-year-old lady who had cataract and needed surgery, but her surgeon needed the primary care clinician to clear her for surgery. Her primary care doctor would not clear her for surgery because her A1C was consistently high. It was chronically high. It wasn't just high. It was 13.2 and above. It was ranging between 13.2 and 13.6%. Mind you, your A1C is supposed to be below 6. At the level of 6, even you're pre-diabetic. And like I said, if you're 13 and up there, you're chronically diabetic, according to the results. So the doctor would not clear her for surgery. This went on for 6 months. They kept on doing the test in the same lab and getting the same results. And she reached out to lab to doctors. We collected the information that we needed, only to find out that when we stopped her from taking turmeric for 3 days, on the 4th day, she retested an A1C that was consistently above 13.2 after 3 days. As though it's that easy to cure diabetes. After 3 days, her A1C was 7.2 just by stopping turmeric.
Wow.
And turmeric actually, there's actually an irony in this, because turmeric is known to reduce blood sugar, right?
Yeah.
People take it to reduce blood sugar, but that's not why she was taking it. It also has an anti-inflammatory component. So like I told you, when people are 40 and above, they start, looking for every way not to take the prescription medicine and drink everything that is in the cabinet. So unfortunately, the same turmeric that is supposed to reduce your blood glucose, which does it, now interferes with the lab method. So it wasn't about, she wasn't even diabetic. She had normal BMI. But the doctor said, I cannot clear you because your A1C is high. So these are some of the issues that we encounter on lab to doctors. She was finally able to get her surgery. Her vision was restored, but who can guess? Her relationship with her primary care doctor ended. The primary care doctor told her that, how did you do it? She said that I would like you to talk with a lab professional who guided me on what to do. And the primary care doctor said, you are not ashamed that you were so frustrated that you went looking for options. I'm going to clear you for surgery, but you're no longer going to be my patient. So she has a new primary care doctor and she has her eyes back.
Wow. That just shows that Lab to Doctors is doing amazing work. And I love the fact that you're acting as the middleman between the physicians, the doctors, and the patient. For example, the example you shared just now could have gotten severe, should have gotten worse. And even sometimes this misdiagnosis even leads to death. Because I read an article where someone shared a personal experience that the person's sister got misdiagnosed due to the fact that the doctor wasn't even listening to what the patient was talking about. So I appreciate the fact that Laughter Doctors is doing such amazing work. And I think we need to have more conversations about this to build awareness for not just patients, for doctors, physicians, basically everyone in the healthcare sector. So thank you so much, Dr. Nan and Dr. Chesie. The box is open if you have any questions for participants. If you have any questions, you can leave your questions in the chat box, and Dr. Chesie and Dr. Nan will be here to answer them. But just before we do that, Dr. Chesie, can you share? Okay, you already shared a story, right? I just want to talk a little bit more about patient preparation, because patient preparation, in the sense that in the analytical phase, right, there are three phases. So let's talk about the pre-analytical phase, right? The patient preparation. Are there guidelines or things that patients should know or should do before attempting to even go for a sample check, get their blood drawn or things like that?
Yeah, if I could talk for the patients, because myself would be a patient one day, I want to put myself in the place of that patient that I needed blood work done. I would want to let my clinician know everything that is entering my mouth, everything that I'm doing, my activities, my lifestyle, any changes that he's not aware. I would like to let him know. But remember that because clinicians are not trained as laboratorians, as laboratory medicine experts, this information is just going to reside with the clinician. If he or she has time, they could investigate on it to guide the patient, or they could reach out to the lab to say, hey, I'm trying to order this test for my patient, and my patient does A, B, and C. Do you think, would there be any reason for my patient to stop doing this or taking this? Again, with the lab staffing shortage, I would say you would be lucky to have someone in the lab to address this in real time. So basically, notify the lab and just sit back waiting for somebody to reach out and respond to you. Not that you have a response in real time to enable your patient have the sample drawn. If you want a response in real time, again, I know I've told you a lot about lab to doctors. That's just what we do. We are there to prepare the patients. But then if for some reason the patient is not prepared and the result is suspicious, you can still reach out to lab to doctor. And just like the patient who wasn't diabetic with the false A1C results, we are going to investigate the results and make sure we remove the interference. Because if you keep on doing the same thing without making changes, you cannot expect different results. So they did the same thing for 6 months and they didn't have different results until they stepped into lab to doctors. Then they had different results. So it's a little tricky with having a lab attend to you in real time. They would do it, but not in real time.
Thank you for sharing, Dr. Chesie. Dr. Nan, do you have anything to add to that from your perspective as a pediatrician?
I think it's important to set expectations with our patients. And for lab testing, that means when we send somebody off to the lab, it is helpful for everyone if we say, okay, you're getting several labs done today. Some of them, the results will come to me in 3 or 4 days. Some of them results won't come to me for at least a week. And you may get them in your patient portal before I see them. You may not, if each patient portal is different. And if you get them before I see them and there's something that's abnormal, please be patient, as I will get through all the labs as quickly as I can, and I will reach out to you.
Okay.
this is particularly pertinent in pediatrics when we do the newborn screening. That's a test that's done in the newborn period. So it's generally done before the baby leaves the hospital, and then again at about around 2 weeks of age. And parents are like, well, this test for like 60 different things. When will we know? Because I know some of these things have to be treated before the baby's 2 months old. And this is true. They do have to be treated before the infant is 2 months old. However, this is one of those tests where people are really at the labs, and the physicians are really that run those labs, not the physicians taking care of the patients, but the pathologists and the geneticists and all the lab people involved in that. If your baby's newborn screen is normal, you're not going to see the results for somewhere between 4 and 8 weeks, because the lab is going to get really focused, and that team is going to get really focused on the abnormal tests. So if you don't hear anything right away, relax. On the other hand, if you do hear something right away, keep in mind, this is a screening test. And it means educating parents on what a screening test is so that, again, you can set expectations. If a screening test is abnormal, we will get a second test that's usually more detailed and more specific. And it's possible that the screening test is a false positive. So before you get concerned, allow us time to do our job.
Thank you. Thank you so much for responding, Dr. Nan. If anyone has any questions for Dr. Nan and Dr. Chesie, please do not hesitate to drop them in the chat box because we'll be ending the session soon. Harper, do you want to go ahead?
Since we are closing or close to closing, I would like to discuss to both Dr. Chesie and Dr. Nan, how might increasing awareness initiatives like this one, just having conversations about patient-induced errors in lab results, serve as a mechanism for minimizing diagnostic inaccuracies?
Repeat that for me, please.
How
There's a
might
lot to unpack in that question.
how might increasing awareness initiatives like this one, just having stimulating conversations about patient-induced errors in lab results, serve as a mechanism for minimizing diagnostic inaccuracies?
I think that kind of speaks for itself, but the question is, how do you build the awareness? How do you make people aware that we have this incredible tool available to us? And certainly some of that's going to be word of mouth. Some of that's going to be reaching out and meeting with people who are medical influencers. And some of it's going to mean sitting down and speaking with medical staff meetings, speaking at medical staff meetings and letting them know. Because this can truly change what we're doing in medicine and how we do it.
And Dr. Chesie, do you have anything to add to that?
Well, I was just going to, I know you said how would it increase, how would increasing the awareness initiatives serve as a mechanism for minimizing what? Diagnostic inaccuracies?
Yes.
Okay. Yes, so if there's increased awareness on patient-induced errors, it would actually empower the patients and the caregivers. It also makes them build accountability on their lab results. And then it could also improve specimen integrity. Of course, coming from a lab perspective, I think I'll be more confident about the results I'm releasing from the lab because I know that the patients and the caregivers are holding themselves accountable on what they should or shouldn't do. It would also reduce the amount of repeat testing. We receive a lot of samples in the lab that were previously tested, but for some reason the clinician needs a retest. So this is like costly, is wasting time and money. and even the
Oh,
resources we have.
Dr. Chesie, we have a question from Barry Curry that says, I have a 37-year-old client with severe mental disorders, and he has been on Kipra and risperidone, but he's constantly back and forth at the ER for lethargic and mood changes. What labs would you recommend he does, and how often? Due
So
to
there's
time
more.
constraints, so let's just just say one or two things on that.
Yeah, I want to say that I would like for her to reach out to me. There's more information to get out of this to be
Yeah,
able to make any recommendations. You know, like I
okay.
said, we take a holistic approach to be able to guide the patients on what to do or what not to do. So just
Yeah.
knowing the medications and being lethargic isn't enough. I think there's a lot more information that I would like to get from her.
Of course, of course. Thank you, Dr. Chesie. Time is fast spent, so we're not having any more questions right now. I just want to use this opportunity to thank you, Dr. Nan and Dr. Chesie, for being here. Thank you for your time. It's really amazing that we got to have this conversation today, and I think more awareness should be, had about this conversation. The pre and school errors that occur are so important to discuss, and thank you so much. Thank you, Harper, my beautiful co-hosts, for being here today as well. And I also want to thank everyone that joined. We have Esther, we have Dr. Ben Ari, we have Naomi, we have Dr. TN, we have Timmy Jr., we have Anne, we have Liz, we have Alima, Dr. Ben, Rebecca, Kennedy, Oluwaseun. Thank you so much, everyone, for joining, for making today's session awesome. So yeah, that will be the end of our session today. So till next time, and of course, I'm pretty sure we'll be having more conversations around this. So yeah. Papa, do
Thank
you
you,
want to say
everyone.
something?
Yeah, I just want to say thank you. Have everyone have a great rest of the day wherever you're at.
Yeah.
Yeah.
Okay, all right. Thank you, Dr. Nan. Thank you, Dr. Chessy. Have a beautiful day ahead. Bye.
Thank you for this
Thank
opportunity.
you.
Bye.
Bye.